Thank you, Vicky. So now we've got Vanessa Sherwood, who's going to tell us about using open prescribing to drive change.
So thanks for the opportunity to talk about how I've used open prescribing. I'm a lead of a small pharmacy team in Weymouth and Portland Primary Care Network. And this is Weymouth on a beautiful sunny day. It's a large PCN. There's 78,000 patients across 5 GP practices. So Weymouth is beautiful, it's big, but it's poor. So there are some deprived areas in Dorset, and most of those deprived areas are concentrated in Weymouth and Portland, unfortunately. And as we all know, deprivation increases the risk of substance misuse, and there is a big substance misuse problem in Weymouth and Portland. And so in my previous CCG role, I'd been to a drug-related deaths panel where oral liquid morphine was implicated in a death in Dorset. And so my colleague and I at the time went back to the office and worked out what actually was in liquid morphine. And so in 300 mils of liquid morphine, it's 10 milligrams in 5 mils of morphine. There's 90 grams of sugar, 3 units of alcohol, and 600 milligrams of morphine. But this is a controlled drug Schedule 5. And so for those of you that don't eat the BNF for breakfast, there are different controlled drug schedules. And Schedule 2 is what us boring pharmacists think about as your traditional controlled drug. So it's subject to the full CD requirements in terms of prescription writing, safe custody, and completing the controlled drugs register. And, my slides are not quite there, are they? Anyway, Schedule 5 are just controlled drugs on the basis that you have to keep the invoices for 2 years. So if you wanted to prescribe 600 milligrams of morphine or 60 Zomorph capsules, that would be a Schedule 2. But in oral liquid morphine, it's a Schedule 5, which makes absolutely no sense to me. So I think there's something there about wonky scheduling. But this is used in acute trusts because without the requirement for prescription writing, without the requirement for safe custody and controlled drugs registers, then oral liquid morphine kind of speeds the process. So especially at discharge and for TTOs, it's much easier to get people out of hospital quicker. And especially where I'm based, I think that's where the problem starts. So, yeah, I'll get off my soapbox about the scheduling. So, but this problem is well known. So in 2021, the Pharmaceutical Journal did an article, and there'd been 13 coroners' prevention of future death reports in the preceding 8 years, talking about oral liquid morphine. And since then, there have been more prevention of future death reports, still talking about oral liquid morphine. HSIB did an investigation in 2022 and made some weak recommendations, in my opinion. One of them was to measure it. And like other liquid medicines, it's not a problem if it's Gaviscon and you take off the lid and you swig it, but if it's liquid morphine, it becomes more of a problem. And also there was a national CQC controlled drugs newsletter where the NHS England South West controlled drugs and medicine safety team highlighted their learning and the issues they'd run into with oral liquid morphine. And at that point, John Hayhurst was the controlled drugs accountable officer, and he and I were always talking about oral liquid morphine. The brand name is Oromorph, I call it Horomorph. And John tweeted this photo, and I got no response to my question about why it was Schedule 5. But somebody at OpenPrescribing very quickly, I think within the same day, tweeted a database of the variation in prescribing across England. And I said you were fabulous then, but my love affair began long before that. So when I moved into primary care, went to work in Weymouth and Portland, I just wanted to see where we were with the prescribing of liquid morphine, and I took it to a prescribing leads meeting for the GP's practices and kind of offered them the challenge and highlighted the risks. And So I managed to set up a search at that point, and every month that drops into my email. It keeps my focus on the topic, and it enables me to offer them updates on the great work that they've done. So since April 2022, can't see my slides, but within Weymouth and Portland, we've done a 60% reduction in the number of items. So obviously those items doesn't tell you what the volume is, but I'm pretty sure my GPs won't have increased the volume on those items. So they've done really good work in Weymouth and Portland, and that's against I used OpenPrescribing preparing this to show how we were comparing locally. And across the NHS Dorset, there's been about a 16% reduction, and 3 neighbouring PCNs, their prescribing has remained at similar levels. So I really attribute this reduction to the hard work of the GPs and other clinicians in Weymouth and Portland. And I went digging about in open hospitals and showed that our local trust had done a 53% increase in volume in the same period. So accepting that I may be not using that database appropriately, and I've got lots of learning to do tomorrow, it just shows again, I think, that Weymouth and Portland have done a really good reduction on a background of increasing or steady use elsewhere. And this was really led by one of our advanced nurse practitioners, who's the prescribing lead and partner at the Portland practice, which will probably have most of those deprived areas. And after the first meeting, she asked for a copy of the photo, and she just took it on, and she tried to stop horomorph liquid morphine in the patients that didn't need it, or she switched them to the regular tablets, which would be a Schedule 2, and so easier to see what was happening. I also work part-time at the trust that's increased the use by 53% for cardiology, but I can't help interfering in anything that impacts on primary care, and specifically my PCN. So I wangled my way into their opioid stewardship group and sat there saying, why do they need a liquid? Why do they need a liquid? And eventually the penny dropped. And when he contacted me and said, can I use your photo? He was going to a meeting about opioid safety, then I knew I was making progress. And in my abstract I submitted, I said that there was just consistent messaging had helped to drive this change, and I just basically nag the hell out of everybody. So whenever I go to a meeting, if I'm talking to community pharmacists, or if I'm talking about prescribing costs or cardiovascular disease, then I normally drop this in as well, just for fun. You can't see this very well, but we have a WhatsApp group for all our prescribers, and the icon of that group is not a picture of me, but it is the picture. But then I just repost it every now and then and say, it's 10% alcohol, do they really need a liquid? And the response that's missing here was a flippant response from a GP, but actually it showed some engagement. So in summary, just thank you to OpenPrescribing. It's really valuable for somebody like me that's running between Weymouth and Dorchester and running between roles, just to have access to this data and be able to use it along with lots of nagging to try and increase opioid safety. And hopefully there's a lot less liquid morphine swilling around in Weymouth, keeping patients safer. Thank you.